You're listening to ExPhysCast, your one-stop shop for anything and everything exercise, science, and physiology. Now here are your hosts, Jamie and Luke Pelton.
All right, welcome to the first ever episode of ExPhysCast. Thank you very much for joining us. My name is Luke Pelton. I am one of your co-hosts, joined by my beautiful, wonderful wife, Jamie. Jamie, how you doing today?
Good, Luke. How are you doing?
I'm doing fantastic. We are super excited to kick off, like we said, the first ever episode with you guys. So, Jamie, why don't you tell us what's on the agenda for today?
First, we're going to break down the basics. Then we're going to get into a lit review where Luke and I kind of explore a study in detail. We'll then move on to our application time and clinical corner. And then we have a very exciting guest segment with Dr. Jackie Day.
Awesome. That sounds like a ton of fun. Jamie, would you mind telling our audience what is our theme of today's episode?
Our theme for today, very broadly, is female exercise performance and how it relates to reproductive physiology in women, including topics such as the menstrual cycle and hormonal contraceptives.
Awesome. Let's get to it. What do you say?
Let's go.
All right. Let's dive into our first segment called Break Down the Basics. Jamie, would you like to start us off with our first basic?
I sure would. So I'm going to talk a little bit about the kind of physiology behind the menstrual cycle, just in case, we're not familiar with all the phases. I know when I first started my research, I definitely was not, which is kind of embarrassing to say as a female, but that's okay. I'm here to explain kind of broadly what happens during each of these phases. So a normal menstrual cycle is roughly 28 days. This is going to vary from person to person, of course. Not every single person is synced up exactly the same. So normal cycles can vary between 22 and 36 days. Anywhere between that is perfectly okay, never really cause for concern. And we have two big overarching phases of the menstrual cycle. One being the follicular phase and the other being the luteal phase. Those are kind of our two longest phases. And then menstruation and ovulation, which you could also consider two kind of sub-phases, occur during each of the bigger phases. So the follicular phase begins on the first day of menstruation and ends with ovulation. It is much more variable than the luteal phase, so this definitely has some wiggle room with how long it's going to be. The luteal phase begins at ovulation and ends with menstruation. This is very consistent. It really does not vary very much. Usually lasts between 10 and 16 days. Again, depending on the person and depending how long their cycle is. With the menstrual cycle, the two major hormones we think about are estrogen and progesterone. Estradiol being the main form of endogenously produced estrogen in the body. So estrogen or estradiol is produced continuously during the cycle. It's very, very low during the follicular phase, and it rises to its peak in the late follicular phase, which then signals the start of ovulation. Progesterone and estrogen increase during the luteal phase, and the increased estrogen causes the endometrium, or the inner lining of the uterus, to thicken and mature. Progesterone then prevents further endometrial proliferation and mitosis, promoting maturation and stabilization of that endometrium. At the end of the luteal phase, estrogen and progesterone decrease, which triggers menstruation, otherwise known as the shedding of the endometrium. I think that's usually what it's kind of referred to as in layman's terms when we're kind of learning about the menstrual cycle and why we're bleeding and what's happening there. The release of estrogen and progesterone is controlled by the hypothalamic and pituitary hormones, which we'll talk about in future sections. And if you're sitting here thinking about all of this and you're like, yikes, why isn't my menstrual cycle like this? Is there something wrong with me?
I was thinking the same thing, actually.
Yeah. Chances are there probably isn't. There's so many factors that control and kind of dictate how your menstrual cycle is going to go. And you don't exist throughout your whole life with the same type of menstrual cycle. Things like weight loss, poor nutrition, overtraining, pregnancy, of course, psychological stress, acute and chronic endocrine alterations. These are all things that can affect the menstrual cycle, even on a month-to-month basis. So if you have, if you're a student, it's finals week, you're super stressed, maybe your menstrual cycle is going to take a hit that month, and that's perfectly okay. I would say, if there is ever a cause for concern, if things, fall out of normal, maybe that's time to go see your doctor. But don't worry too much if your menstrual cycle or your entire cycle doesn't fall within these parameters. I wouldn't worry too much about that.
I think this is a great time to remind our listeners that everything spoken about on the ExPhysCast is purely speculative and educational approach. We are not medical doctors. So if you have a medical question, please do not look to us for guidance. Please go to a licensed healthcare professional, doctor, PA, DMP, whatever it is going to be. No, Jamie, I thought that was great, and I like how you touched on the fact that it is so variable. The endocrine system in the body is almost looking for reasons to be affected and go wrong.
Yes, which I'm sure most women will tell you the same thing.
Oh, absolutely. Absolutely. I think a lot of that also is due to the lack of good information and research performed in female subjects, which was, I think, part of the reason why we had a lot of people asking for this topic or theme for today's episode.
Yeah, definitely.
Awesome. Very cool. Well, actually continuing on the topic of hormones in the body and their finicky nature, I'm going to briefly introduce something called the hypothalamo-pituitary gonadal axis. All right, so if we break that down, the hypothalamus is a brain region. Pituitary is a gland just south of the hypothalamus in the brain. And the gonads are, they're the gonads. They are the sexual organs, testes in males, and the ovaries in females that are responsible for our reproductive cycles and the hormones that we produce. So the highest control center of this axis is, like we said, the hypothalamus in the brain. So it consists of neurons. It's neural tissue. It's found in what we call the arcuate nucleus, or the preoptic area. And in this region of the hypothalamus, a hormone called gonadotropin-releasing hormone is synthesized. All right, so it's a hormone that causes the release of another hormone. So this is transported to nerve terminals in the hypothalamus. It's stored for future release. That's a key factor. A lot of hormones aren't stored for long-term use. Some are found in the blood with a short half-life. Some are stored for future use. This one is because it's released in a pulsatile manner when it's needed. So what happens is the hypothalamus releases this gonadotropin-releasing hormone to the anterior pituitary, via what we call the long portal vessel. And this is found in the hypothalamic pituitary axis, kind of a highway that connects the two. So it sends this hormone, down the long portal vessels to receptors of gonadotrophs, which are found on the anterior pituitary gland. This GnRH has a half-life of about 2 to 4 minutes, so it doesn't stick around very long, hence why it's released in that pulsatile manner. When the anterior pituitary gets this gonadotropin-releasing hormone from the hypothalamus, it itself releases follicle-stimulating hormone and luteinizing hormone. So I think if we break down those words, we hear follicle and luteinizing. So if we think back to what Jamie has talked about with the follicular phase and the luteal phase, we start to see how these things are very directly related. So the secretion of these two, we're going to call them FSH and LH just for shorthand. It's also pulsatile, and they're mainly released during REM sleep, starting at puberty. And as we see changes in the release manner from REM sleep throughout the day as we grow and mature. So the follicle-stimulating hormone acts on what's called granulosa cells. These release estrogen and ovarian follicles. And again, we are speaking mainly about the female anatomy and physiology in this episode. These are present in males as well, but most males do not have ovaries. So we're going to focus again on females for today's episode. I'm going to say most because there are obviously rare cases in which that does not apply. So that, like we said, that's FSH going to the granulosa cells, releases estrogen. Luteinizing hormone acts on what we call Leydig cells. This releases testosterone and other androgens. It triggers ovulation, and it helps transform the follicle to the corpus luteum, which is an integral part of the menstrual cycle. So estrogen and testosterone levels, they're going to form what we call a negative feedback loop with the anterior pituitary. So this is a signal of I'm being produced, therefore you can stop producing the things that produce me. All right, so if we have enough of something, we don't need too much. That's that negative feedback loop. You're doing great, but please stop. There's another hormone called inhibin. If we think it sounds like inhibit, that's kind of its purpose. So it goes back to the anterior pituitary and says, hey, we're good. You can stop now. We also have estrogen that acts on the hypothalamus directly with that inhibitory approach. And once estrogen and testosterone are released, we're going to see that they act on the reproductive tract and lots of other organs such as muscle. And that's another key theme that we're going to talk about a little bit, the interaction of mainly estrogen today. I'm sure we'll get to testosterone in a future episode. We've already had a lot of requests for that kind of route. But again, today we're talking about estrogen and its effects on muscle. Speaking of estrogen, Jamie, tell me a little bit about hormonal contraceptives.
Alrighty. So I'm going to talk about a few different types of hormonal contraceptives, mainly because one of the studies that we're going to highlight in our lit review coming up talks about specifically second generation hormonal contraceptives. So I'm just going to highlight the differences so we can get a little bit of an understanding of what it means by, first, second, third, and even fourth generation hormonal contraceptives. So the main difference is the type of progesterone being used. In first generation hormonal contraceptives, we're usually talking about a typical oral contraceptive, so a pill. These have much higher concentrations of both estrogen and progesterone, and they're not super common anymore due to a wide variety of adverse reactions. I think after that first generation of birth control came out, I'm sure researchers wanted to find a more minimal effective dose type of pill or product to give females. That way they would still get the benefit of the contraceptive, but not the adverse side effects that come along with them. So second generation, which will be spoken about in, again, a future study that we talk about later in the episode, these have much lower amounts of hormones. Again, kind of like that minimal effective dose, not as many side effects, and definitely more desirable amongst females. And then third generation contraceptives can be in the form of oral contraceptive or something else, such as a patch or something like the NuvaRing. And then the fourth generation contraceptives are the much newer, as you could guess, the newest thing that has come out. So I think one of the newer options on the market now is Yasmin. I've heard about that recently, coming about maybe within the last couple of years, so pretty new. And then important to note that, these are going to be prescribed by your medical doctor, but usually by an OBGYN. So it's not great to compare, what you're on versus what somebody else is on. It's going to be very individualized. Some people may react to the levels of hormones differently. Some people may get side effects using a pill or a patch or an IUD, intrauterine device, something along those lines, while another person using that same type might not. It really depends on how your body responds. The end goal is to provide the prevention of unwanted pregnancy or even alleviate some kind of menstrual related signs and symptoms. Sometimes, we can be prescribed these pills or devices to alleviate acne, treat irregular menstrual cycles. It can help mitigate signs and symptoms of polycystic ovary syndrome, endometriosis, so on and so forth. So the main takeaway is that, these are all individualized. Listen to your doctor and follow what they think is going to be best for your body. All right, so moving away from the contraceptives and kind of reproduction side of things, Luke is going to tell us a little bit about how estrogen plays a role in muscle.
So like Jamie said, estrogen does directly impact muscle in both sexes, but obviously we're focusing on female physiology today. Estrogen is what we call a steroid hormone, which means that its original formation is actually cholesterol, as I'm sure many of us are familiar with. So via a series of conversions in the body, cholesterol is converted to a hormone called pregnenolone, which is then converted to the aforementioned progesterone. That itself is converted to androstenedione. That is what's converted to testosterone. Now, testosterone is, I guess, what we call the main steroid hormone if we think in terms of physiology. And estrogen is actually formed from testosterone via aromatization. So it's the conversion from test to estrogen via a very cool little enzyme, cytochrome P450. We actually see that present in caffeine metabolism as well, which I have my own little theories on the relationship between the two. That's not for this episode. I think we touch on caffeine in one of the future episodes we were deciding.
I'm sure we do.
Yeah, somebody asked for it.
About caffeine.
Yes. Why does it keep me up at night? Well, that's why. So there are estrogen receptors, both alpha and beta form. We're not going to get into the differences between the two today. They're present in all musculoskeletal tissues, mainly muscle, bone, ligament, and tendons. And what these receptors do is they allow for the modification of gene expression, right? That's kind of the end role of steroid hormones. They modify gene expression. So estrogen is very beneficial for muscle mass and strength. Again, this segment, I'm not really looking at the reproductive benefits as much. This is an exercise physiology podcast. Therefore, we're focusing on the exercise components. So we actually see increases in kind of hypertrophic potential with good levels of estrogen. And we see increases in the collagen content of connective tissue. However, what this can actually cause is a decreased stiffness of connective tissue, which can lead to increased joint laxity. And if it's too high, we can see this actually limiting performance and power output due to the lack of rigidity and structural stability found in hypermobile joints. We also see more ACL ruptures in menstruating women than we do in males. Now, as a side note, I'm not going to pin that solely on estrogen. Obviously, biomechanical factors like Q angle, the width of the hip compared to the knee. We've also seen some evidence of quad to hamstring muscle imbalance ratios, kind of all gas, no brakes, being a contributing factor here. But the estrogen definitely is a contributing factor in that capacity. A lot of the studies that we've seen in regards to estrogen's effect on muscle have been in aging populations, especially post-menopausal female populations, because that is directly associated with decreases in endogenous internal levels of estrogen and contributes heavily to muscle and bone wasting. All right? I'm sure a lot of us are familiar with osteoporosis being a serious condition that plagues many post-menopausal women. Estrogen has a very protective role in muscle and bone health and integrity. So estrogen, or estradiol, as Jamie mentioned, has been shown to have beneficial effects on muscle in postmenopausal women via hormone replacement theory or hormone rescue therapy. And it actually accomplishes this by improving the intrinsic quality of skeletal muscle, which enables the fibers to better generate force. It's not so much hypertrophic muscle growth, but just increased contractile properties of the muscle. Estrogen also plays a heavy role in cellular metabolism, so it maintains good mitochondrial function. Again, the mitochondria is the powerhouse of the cell, center of aerobic metabolism, and particularly it has a positive effect on two proteins called complexes 1 and 3. These are part of something broader called the electron transport chain, which is the major site of oxidative phosphorylation, by which we get ATP or energy in the mitochondria. If estrogen is too low, we actually see increased mitochondrial hydrogen peroxide and decreased antioxidant activity, such as decreased glutathione peroxidase and superoxide dismutase, and impaired insulin sensitivity. And these are due to altered redox potentials of the cell, which is kind of the back and forth trading of electrons to maintain positive, negative cellular environments. And we also see impaired glucose homeostasis, which can lead to decreased insulin sensitivity. So estrogen obviously has a lot of effects on muscle, and some of the studies that we're going to talk about are going to take an in-depth look at how that happens. So that concludes our breakdown the basics segment, and we're going to seamlessly transition into our lit review, where we each for this episode have procured one recent piece of research which we thought kind of nicely illustrated these physiological basics we just spoke about. Jamie's going to start us off with a piece she found. Jamie, what study did you find for us?
I found a study done in 2020, so recently, within the last year, by Dalgaard et al. The purpose was to investigate whether the use of second-generation oral contraceptive influences adaptation in muscle mass and strength in response to 10 weeks of resistance training compared to a group of non-users of oral contraceptives. They hypothesized that the use of second-generation oral contraceptives would enhance muscle growth and yield improvements in muscle strength when combined with resistance training. The participants were females, ages 18 to 30, so kind of a small age range rather. They included two groups, so one group had users of second-generation oral contraceptive users, and the other group were non-users. They were roughly equal in participants, so there were 20 users and 18 non-users. I believe there were one or two people that eventually dropped out of the study due to pain associated with some of the testing procedures that they were doing, which kind of accounts for those two people that were missing from that non-users group.
I'm going to pause here, Jamie, since I'm a research nerd. What do we call that dropout of participants?
Attrition.
Oh, very nice. Very nice.
Making my husband proud.
It's about time. No, I'm just kidding. Always, every day. We actually, dear listener, you may also see this called mortality. I think they use attrition because that just sounds a little less macabre. And, it sounds like people are dying during the study. And we don't want that happening at all.
That did not happen.
No, which is why we get IRB approval. I'm so sorry. Please continue.
Thank you. All right. So for their methods, their first visit was kind of a familiarization session, which is typically seen in a lot of training studies to kind of get the participants used to what they're going to be doing. They also determined pre-existing physical activity status determined by a questionnaire, and they also obtained height and weight for each participant. So the official day one, so the start of, actual intervention, they did an MRI or magnetic resonance imaging of the thigh muscles. That was it for day one. They came in the next day after an overnight fast, and a muscle biopsy was taken from the quadriceps and blood samples were obtained. So that's kind of what I was touching on previously. I believe 2 people ended up dropping out of the study due to pain related to that muscle biopsy, because if anyone has ever gotten one of those done, they're not fun, and they can definitely give you some soreness, which maybe people weren't ready for.
It's only the size of a grain of rice, but it's really crazy how much taking a piece of your muscle out.
Oh yeah.
Makes your muscles sore. Go figure.
Go figure.
Yeah.
Yeah. So on day 2, that same day, body composition was tested using dual energy X-ray absorptometry.
Absorptometry.
Yikes.
What do we call that for short?
DEXA.
There we go. Yeah. Yeah. DEXA or DXA. We might see this. And I know some people around me who have gotten it done too. It's a little expensive, but it definitely is the gold standard.
Right. A lot of schools, universities, colleges kind of have them that you can rent out or pay for a session, and they'll give you a printout of all your results if you're interested. But anyway, getting back to our study, the last couple of things they did on that day was a modified Wingate test with a counter movement jump, as well as a 5 RM leg press test to determine muscle function. Moving on, they started their training protocol, which consisted of 10 weeks of supervised resistance training with 3 sessions per week with specific emphasis on lower body exercise. Each session was about 45 minutes, and participants were instructed to train using near maximal effort and train to momentary muscle failure. So this was stayed consistent across all participants, which is why it was a supervised session. They really wanted to make sure that those conditions were the same amongst each participant. The blood samples were taken to assess a bunch of different hormones. So they looked at dihydroepiandrosterone, or DHEAS. They looked at testosterone, estradiol, progesterone, sex hormone binding globulin, luteinizing hormone, and follicle stimulating hormone. So lots of different things. The results, unfortunately, their hypothesis was rejected. The use of second generation oral contraceptives did not promote significantly greater gains in muscle mass after 10 weeks of resistance training in young untrained women. And overall, I would say the takeaway from this, and they even mentioned this kind of in their limitations, was that future research should be conducted exploring these same effects with a longer training intervention. 10 weeks is pretty short. I think most things that I've seen, Luke, you can correct me if I'm wrong, with training intervention is typically a 12-week protocol.
Yeah, that's usually the minimum that we see. That's
right.
Usually that like threshold for any kind of physiological change to actually start occurring.
Exactly, right. I'm assuming that since they took untrained individuals, maybe they thought they could get away with 10 weeks to elicit changes, but as we see, maybe this wasn't enough.
So here's the double-sided sword with untrained individuals, is that they don't have like a normal adaptation response to stimulus.
Right.
If you have a trained individual, and again, I guess I'm getting ahead of myself. As long as your sample is uniform and you're seeking to generalize those findings to a broader population that is represented in your sample, it's technically fine. So what we could say from this is if we took a large group or every untrained individual in the world, basically, that fit these same criteria, they would have the same results. That's all we're saying from this. So I think this is a good time to kind of have a little research segment, very brief, nothing formal on the books or anything. A lot of the times we see generalizations or conclusions that are erroneously pulled from studies. Studies have very specific parameters of what they're analyzing, how they're analyzing it, what populations it should be generalized to. So be very wary, dear listener, if you ever hear or see, a new study has proven that anything, just continue reading, but just take it with a grain of salt, because no study proves anything.
Right.
The research that we're doing, quantitative research, which is numbers driven and statistics driven, kind of acts under the auspices of the concept of ontology, which is the search for truth. And the idea behind it is that we can get very close to truth, and we strive to get as close as possible to that one singular truth, but we can never get all the way there because we are humans, and to err is human, obviously, and forgive divine. But humans make a lot of error. We build error into our studies. We account for that. All right. A lot of statistical measures account for all sorts of error that we're going to conduct in our research. So until computers rule the world and they run the studies, we're going to have that error component. So we can't prove anything. We draw conclusions from inferences that we make in the data.
Right, exactly. Yeah, and that's pretty much exactly why that results statement is so long, because they are saying, in this population of young untrained women, this is what we find, or what we found rather, or lack thereof. They didn't find much, unfortunately.
Yeah. Which is still a finding.
Yes.
It's still good to know.
Yes. So, and additionally, just to tack on to, longer training intervention, as I mentioned previously, a larger sample size would probably be of benefit. 28 is not a huge number when it comes to quantitative research. So it would be nice to see something like this done in a much larger sample size, much larger population.
This is the curse of exercise science. We are plagued with tiny samples.
Oh, I know it.
Psychologists get thousands and thousands and thousands of people. We're like, oh boy, 50, that's huge. Cool. Well, Jamie, that was a very interesting study. I'm wondering their original substantive hypothesis about what they thought was going to happen. They were expecting a change.
Yes.
So I'm wondering what previous research was done that suggested that, and where they went wrong in their own study.
Mm-hmm.
I mean, we mentioned sample size, but anything else you think that might have made it different than that previous research?
I'm not sure. I can't say definitely, but I know that the research that does exist, at least the research that I'm aware of that exists surrounding this topic, has always been inconsistent with their findings. You get one study that says one thing and another study that does something similar and finds, something else. So I think they were just, kind of trying to go with what they got based off of a previous study that maybe suggested that, hormonal contraceptive might, or exercise and hormonal contraceptive might have these effects. But I'm not sure. It's hard to say, especially because there really is a large lack of research in this field. So there's really not much to compare. They could have also just taken what we know about, estrogen and muscle and all of these things and created a hypothesis off of that. But it's hard to say.
That's a good point. And you are kind of our little resident in-house expert on this topic since you're writing your thesis on it.
I don't know about expert, but I'm getting there.
Experienced.
Yes.
Yeah, we're going to talk about that a lot later on during our application time / clinical corner segment, which is going to come up actually, I think, after this segment. Yeah.
So Luke is going to kind of lead us into our next study that we're going to be looking at as part of our lit review. So Luke, do you want to tackle that for us?
Sure. All right. So I found a study, a Finnish study by Myllyaho et al. From 2021, so incredibly recent. Now, again, that usually means that the research was probably done in the year previously. It takes a long time to get research peer approved and published. But again, this represents kind of the cutting edge of research in this area. They were looking to investigate the effects of hormonal contraceptives, as is the theme of the day, on strength and endurance training in females, obviously. Not a lot of hormonal contraceptive studies with men.
No.
Probably for good reason.
Wonder why.
So they used, like we said, female population. These were 18 healthy, physically active women.
Okay.
And they kept it between the 24 to 41 year range, simply to eliminate the possibility of like that kind of early eumenoric or postmenopausal female populations, kind of keeping kind of even hormonal playing field, as it were. So they divided up into 2 groups, 9 in each group. So unfortunately, like I said, small sample size, small groups.
Sample size.
They did what they could with what they had.
Yes. So
more credit to them. So the one group used hormonal contraceptives, and one was simply a normal menstrual cycle group that they said either not or never using hormonal contraceptives. So I would just say not using hormonal contraceptives because, I mean, that could imply that they have previously, but now they're not. So listen, could have been a translation thing. That's what they defined it as. That's what I'm reporting. So they specified also in that hormonal group, the hormonal contraceptive group, they could be either using a monophasic combined pill, a progesterone-only medication, or the intrauterine device, like Jamie mentioned earlier. They designed the study as a simple pre-test, intervention post-test, which is an incredibly, probably the most common exercise physiology study design we're ever going to see. And the intervention itself was 10 weeks of high-intensity combined strength and endurance training. They lifted and ran for 4 sessions a week. They had 2 strength and they had 2 running sessions within those 4 sessions. The strength sessions focused on the lower extremities, like in Jamie's study too. Intensity ranged anywhere from 50 to 85% of a tested 1 rep max. In these sessions, they performed resistance exercise, followed by plyometric exercises. And I should say that this is styled in the contrast training scheme. So they paired heavy resistance exercise with an explosive plyometric exercise like a box jump or a med ball throw. Contrast training is pretty interesting. I encourage you to go out and read about that after the show.
Hey, maybe we'll have an episode on it later on.
Maybe we will. That'd be a good idea. I'll write that down in the show notes. The endurance sessions were 1 high-intensity session, which consisted of 4x4 running intervals from 70 to 90% heart rate max. I realized here I forgot the hyphen, and I wrote 7,090% of heart rate max.
Wow.
That person is generating the sun. And they had 1 sprint session, which was 3x3 by 100 meters of an all-out 100% intensity. They were kind of given free rein. So this was not supervised, but they were told they couldn't train the same modality, so either strength or endurance, 2 days in a row. And they couldn't train 4 days straight in a row across the 2. This was to make sure they were properly recovered between each session. And again, these are not really easy training sessions, so even in a trained population, they definitely need to rest and recover. They tested everything during the follicular phase, which I thought I thought at least that was a good distinction, that they made sure to uniformly test
Yes.
in the same phase so that hormone levels are going to be even across.
I've actually seen a lot of studies in my research that didn't look at the menstrual phases, pretty much all of those studies reported in their limitations that they should have done so to allow for some kind of control, because there's so many different things happening depending on what phase you're in, so it really is important to control for those phases.
This is why it's so important to report everything you find and to get non-significant findings published, because researchers need to see what didn't work.
Exactly.
So they can base their research on kind of the failures of the past, and they can build off of that. Anyway, I could go off for about 20 minutes on that alone.
I'm sure you could.
Yes, and you've heard it before. So the testing measures they employed, they used a max effort bilateral dynamic leg press, simply a 1RM test, and they also did a max bilateral isometric leg press set at a knee angle of 107 degrees. So this is where they measure torque and force output at a fixed joint angle. They also measured a counter movement jump on a force platform, which is pretty interesting. They can use that to estimate flight and landing force, to estimate jump height and time. They also did a 3-kilometer running test where they recorded their split times and their heart rate during that, and they measured body comp with a DEXA scan. So those are two great examples of a gold standard body comp measure. And finally, they measured serum hormone levels, so total testosterone, follicle stimulating hormone, luteinizing hormone, estrogen, progesterone, sex hormone binding globulin, which is simply a carrier protein that testosterone and estrogen bind to carry around in the blood, cortisol, and IGF-1, or insulin-like growth factor 1. So after everything was said and done, they found that strength and endurance had both improved similarly between the two groups, both the contraceptive and the non-contraceptive group, over that 10-week combined training period. There were no significant differences in body comp changes. They did find that luteinizing hormone decreased from pre to post in the non-contraceptive using group. And they kind of concluded that women using hormonal contraceptive may make improvements to strength and endurance without disrupting that previously talked about hypothalamo-pituitary axis, and without having any negative effects on their hormonal concentration. So they kind of use these null findings as women using birth control should be able to exercise just about the same as women without, with no adverse effects, which is always a good thing to find.
Yes.
All right, we now move to our next segment, the application time segment, where we seek to take the principles and mechanisms we spoke about already and talk about how we're using them in the real world today. Jamie and I are both practicing exercise physiologists and researchers. We've got a fair amount of applied and theoretical experience in these areas. So I actually want to turn over to Jamie in a segment we're going to call Jamie's Clinical Corner. Jamie is kind of our resident clinical exercise physiologist, and she is conducting a study that incorporates pretty much everything we've talked about today. So Jamie, why don't you tell us a little bit about your research?
Yeah, so my master's thesis is looking at the use of hormonal contraceptives and resistance training on the vasculature. I got interested in this topic mainly because I am a competitive powerlifter, so resistance training is part of my everyday life as well.
Every day but Sunday.
Every day but Sunday. As well as the fact that I am and have been on a form of birth control for, the last decade of my life probably. And in just casual conversation with, my peers, this has always been a question of how do these hormonal contraceptives affect the adaptations to resistance training? And how can it, either hinder or advance our progress in the sport? And when I kind of looked for the research, I didn't see much out there. I really didn't see anything out there specifically in powerlifters. But I really didn't see much out there to begin with. So I really wanted to look into it. And, as an aspiring clinician, I wanted to add something in terms of the vasculature in there, especially because we know, and what I've learned in the last 2 years in my program is that estrogen is cardioprotective. So I wanted to see if, exogenously dosing these hormones, does this enhance the cardioprotective benefits of estrogen? Does it just react the same way in the body? So these are all questions that I had and still have going into, and as I complete my research, I would like to see if these things have any benefit or adverse effects on arterial stiffness and the vasculature.
Sure. Also, we know from previous research, obviously, and just knowledge that resistance exercise itself is going to drive up arterial stiffness, right? So it'll be cool to see the way you have your group stratified, those using and engaging resistance exercise, those using and not, et cetera, et cetera. That clinical angle of, is exogenous estrogen enough to counteract resistance exercising induced
Exactly.
arterial stiffness. So awesome. That's really cool. And I mean, I've been with you every step of the way as you've designed this study. And Jamie, what would you say is the biggest setback that you're experiencing with your study right now?
COVID-19 is my biggest setback, as I'm sure, everyone can relate over this past year that has been a major setback in more ways than one. However, it's definitely been difficult to gather enough participants, especially with, all the rules and regulations that the college has put into play, which, all makes sense, not complaining about rules and regulations. That keeps us safe. But definitely tough to deal with as a master student, nonetheless.
It's that small sample size that we mentioned earlier.
Yes. Yep.
Here you see it applied in real life.
Yeah. So, Luke, why don't you tell our listeners what else we're working on lately?
Oh, yeah. So Jamie and myself, along with another strength and conditioning master student, we're in the process of assembling a systematic review of literature. So in general, review of literature is just a amalgamation of all the findings that are currently out there in regard to a certain topic. What makes this one systematic is that there's a certain codified approach to searching for studies and including studies in this review. So it's very rigorous, it's very procedural, but hopefully the end goal is the most scientifically informed presentation of all the knowledge surrounding a current topic. And we are looking to perform this systematic review on not only how the menstrual cycle phases affect female exercise performance, but how nutritional interventions are related to the two. One of the big things we see in female athletics is something called the female athlete triad, which, and Jamie, please correct me if I get these wrong, but it's amenorrhea, so cessation of the menstrual cycle, disordered eating in any form, and osteoporosis.
Yes.
Right. So we kind of mentioned the osteoporotic angle with the postmenopausal female population and how estrogen is linked to decreased bone formation, increased resorption, which actually is what we see in outer space as well. So there's a lot of crossover between osteoporotic research and space physiology, which is my nerd area, which I hope somebody asks for this as a topic, because I would love to spend an
Nobody
entire...
asks, I'll ask. That way you can...
You know what?
You can talk about it.
What a great wife. Thank you. As if she doesn't hear me talk about this enough. So we see the connection there, but the disordered eating side is a massive, massive component. Unfortunately, this usually manifests in restricted eating, caloric restriction, whereas athletes should be eating.
Yes, almost in abundance, if anything.
Yeah, lots of good, I mean, wholesome
of course
foods.
Yes.
Performance-driven foods, which, again, we could spend an entire 10-hour podcast series just talking about sports nutrition in general. We have some great guests we could bring on there as well. So we're just coming up with new topics right in the middle of the old ones. Sorry, hormonal contraceptives. We'll get back to you in a minute. So yeah, really excited to see the findings there, and we can begin to call for certain pieces of research to address any gaps that we find. Jamie kind of mentioned this earlier, but there's a paucity of research in female athletes just in general, unfortunately.
Females in general.
Yeah, it's oh god. It's the saddest thing. Just the amount of studies we've had to thrown out of our review process just because it's a male population. And again, nothing against males. I myself happen to be one. But man, when you're looking for female populations, it's almost really hard to find these niche topics sometimes. So hoping to make those a little less of a rarity.
Yes.
And more of a commonality.
Yes.
Jamie, anything else to add to our clinical corner application section?
I think that's good. I think we touched on all of the points we wanted to make, tied in kind of all of our things from the breakdown of the basics. So I think we're all set.
I'd agree. I personally am very excited to get to our guest.
Yes, as am I.
All right, so let's turn there now. Today we're speaking with Dr. Jackie Rickson. She is a research assistant at Smith College in the Exercise and Sports Studies Department, where she coordinates research under Dr. Sarah Witkowski, who herself is an eminent scholar in the field of female, especially menopausal and cardiovascular disease risk. Jackie completed her PhD at Springfield College, where for her dissertation, she looked at vessel stiffness in relation to physical activity. We're very excited to talk to her. Please welcome Dr. Jackie Rickson. Jackie, how are you today?
Hey, people. I'm fantastic today. Just happy Wednesday to you and happy Wednesday to everybody out there.
Indeed. All right. So for our folks listening, this interview is about 2 weeks old, but we are still speaking to you somewhat live from our home audience here. All right.
All right, Jackie. So let's start off with our first question. Tell us a little bit about your field, your focus, your specialty. What are you kind of all in for? What's your interest?
Yeah. So I think my interest really first started off in graduate school when I was under the advisement of Dr. Sam Headley. And with Dr. Headley, I was looking at a lot of vessel stiffness stuff. And myself as a graduate student, which I'm sure the two of you are very aware of, we try to get our exercise in, but the majority of our day is sitting on our butts and clicking through on a computer. So, so I was interested in seeing if sedentary behavior had an impact on vessel stiffness in people who meet physical activity guidelines. And it looks as though it might, which is pretty interesting from the data that I got from my cohort. So that's really where the start of my career in research began. When I got my position at Smith College, there was a female focus in focusing on menopause, specifically perimenopause, and how there's a pretty dramatic increased cardiovascular disease risk within the perimenopausal period. So in realizing how much and how little research there is in physical activity and menopause, it's the timing of being involved in this type of research is fantastic. So I'm really excited to be further looking into sedentary behavior specifically, and how that impacts vessel stiffness, and maybe how physical activity can modify the relationship between sedentary behavior and vessel stiffness and vessel function. So that's really where my focus is at this point.
Awesome. So cool. Very cutting edge, like you said. And can you clarify for our listeners the perimenopausal period, what that exactly entails?
Yeah. So there's really three big stages in female reproductive cycling, right? So we have premenopause, right? Anybody who is still menstruating regularly, and usually under the age of 43. So most times we don't see any big changes in menopause or moving to the transition of menopause until around 40 to 43. That can be that's very variable. among people and individuals. And that's what makes menopause kind of difficult, is that it's not a one size fits all. But we all go through it. So it's important for us to research it. Or by we all, I mean all of us females. We go through it.
The odd one out here, unfortunately.
Sorry, Luke, we're leaving you out of that.
You know,
Yes.
I think I'll let that one slide for this time.
Good, you should. It's not a great time, apparently. So anyway, perimenopause is that transitional period between pre and postmenopause. So postmenopause is timing after the last menstruation. So after that last cycle, usually that's identified by 12 months or more of amenorrhea. So loss of period for more than 12 months, you are now considered postmenopausal. So that middle ground, there's actually some categories in between, being early peri, mid peri, and late peri, all which are essentially defined, can be defined quite differently. I'd have to look up the very specifics because they are very specific. And again, I'm new to menopause. I'm the vascular researcher that came into this, but it's still pretty interesting. So in the study that I'm coordinating, the perimenopausal women that we're looking for have periods that are equal or greater than 7 days different between cycles. It's like, wait, math? Let's do some math real quick. So what that means is that if myself as a perimenopausal, as a female who was in the age range of 43 to 54, that's usually where we see perimenopause occurring. Let's say I get my period on March 1st. I should expect my cycle to be between 27 to 30 days, right? So I would expect to get my period again, let's say the 28th of March. Now, if I didn't get my period for another 7 days on top of that March 28th, so that gets me to like April 4th, 5th, or 6th, right? If I didn't get it till then, I could qualify as perimenopausal. But that would need to be, that cycle and that difference of 7 days would need to extend for at least 6 months, right? So I need to have varying cycle lengths that are equal or greater than 7 days for at least 6 months in order to qualify for the study that I'm looking at. You can still be perimenopausal and not be at 7 days, but that's the range that we're looking at. So sorry for the long wind.
Quick question about perimenopause. Have you seen or have you looked at if there's any relation to meeting those physical activity guidelines? You know, let's say you're an active person. Is the onset of that kind of perimenopause pushed back? Does it still vary a lot between individuals? Have you looked at that a little bit?
So that's actually that's part of what we're looking at with the study that we're going to be conducting. Like I said before, unfortunately, there's really not good and not quality research that's been done on this. And we, as far as I'm aware, the group that I work with are one of the only group of physiologists that have been into menopause. So a lot of anthropologists study menopause. And unfortunately, some of that translates into the research methods. And the quality and the control from a physiology perspective is sort of lacking in the research. So that's part of what we're doing. There's really no good answer for your answer right now. We don't know. But we're excited to be looking at and comparing the differences between habitually low active women and habitually very high active women, to see if maybe there's a difference in the hot flash experience specifically. There's a lot of different symptoms with menopause, but we focus on the vasomotor symptoms.
Awesome. Thank you.
Yeah.
Very fascinating stuff, and it's very refreshing to see. Well, I guess I should backtrack and say that it's sad to see such a gap that hasn't been addressed, but it's refreshing to see new cutting edge research being applied towards that discrepancy in the research. It's always something that I like seeing, that gap area really being attacked heavily. For our listeners, can you kind of speak a little bit to estrogen's overall role in vascular health? Because I know that was like what you looked at, especially in your doctoral research as well.
Well, actually, I didn't in my doctoral research. So I didn't focus on females in my doctoral research. I focused on both men and women. And the only criteria that they had to be was healthy and meeting physical activity guidelines. So I am really new to the hormone, the hormonal changes associated with menopause. I do know that estrogen seems to have some role with nitric oxide impact, and essentially the signal that gets sent in order to allow nitric oxide in order to be released, which gives our vessels the ability to change their luminal size and expand or dilate or constrict. So we think it has something, that's where the mechanism is. But again, the jury is still out on a lot of things in relationship to menopause, but also I'm new in menopause. So unfortunately I can't tell you too much.
Right. Well, I know a lot of what we've learned in our studies is estrogen is cardioprotective. Estrogen is the mantra, and which is why that when we look at like risk factor stratification for aging populations, heart attack, heart disease, it's always pushed back about 10 years in females as compared to males because of those estrogenic levels.
Right.
I've also seen some research in the past that suggested that testosterone, blood testosterone, actually mediates vasodilation independently of that enos cascade. So it's interesting that you brought that up, and like the endocrinology surrounding it, all of the signaling cascades in the vasculature is just fascinating and complex, like you said. So I'm really looking forward to see what are the breakthroughs you make in that area.
Yeah.
So very, very cool to see.
We're focusing, we're actually, not to interrupt you, but we're looking at endothelial microparticles, or EMPs, or microvesicles, which essentially give us an idea beyond the subclinical cardiovascular disease risk that we see with vascular function. We're actually looking at these little microparticles that essentially release off. They seem to be a signaling molecule that says to the immune system, hey, this vessel needs some restructuring. This vessel is not doing so hot. The more EMPs that we have circulating in our bloodstream, the more response we need to be sent to those vessels in order to essentially fix them. So those little EMPs are actually becoming a really good marker for cardiovascular disease risk, and something that we can look at before we hit atherosclerosis at a greater length, or greater vessel stiffness, or loss of function in the ability to dilate and constrict the vessel. So we're actually developing a whole protocol that has not been developed in the capacity that we are attempting to. Wow. So it's really, really exciting. We're doing a bunch of like super cutting edge stuff that just my mind is blown that it hasn't been done yet. Like we have all these women on this planet. Why are we not studying them?
I know. I mean, go ahead. Sorry, Jane.
I was going to say that was my exact question as I was kind of gathering sources and, writing my lit review for my thesis. It's like, where is any research regarding any of this? And I really couldn't find any. Like, there really wasn't, or it's like there was research in like one aspect of it but not tying everything together, and I was like, where is this? Why don't we have any of this? This is something that, all women deal with. So it's part of our natural reproductive system. So why is this not studied?
Well, we're seeing the trickle-down effects of obviously lots of historical things that we're not going to touch on in this podcast, unfortunately. It was all clinical population. Then it was, exercise sports science in male populations. And now we're only starting to see finally, female populations, which is, refreshing to see. And what a thrill for you to be a part of this surge forward. Really, really, really awesome stuff.
Yeah.
Yeah, awesome. So it was really awesome having you. Really great getting another person's perspective, somebody that's, in the field, doing the research, doing all the work that needs to be done. Is there anywhere that people can find you or follow your research or anything like that to kind of, if they're interested, stay up to date with all of that?
Sure. So we have our own lab website, which my brain is blanking on the actual name. But I can certainly send that over to you guys so that you guys can put that wherever would you see fit.
Sure. We'll throw that in the show notes underneath.
Excellent.
So you can access that.
Cool. And we also have a lab Instagram that we're starting. A few of the students within our lab are going to be generating what I think is going to end up being a meme page related to women's health. So we're super stoked about that. So that would be the two best places to probably check out our work and see what we're doing. And then obviously can always reach out to me on Instagram or or via email. My Instagram handle is @Dr. Jackie Day. Or there could be an underscore in there. Again, you're going to have to show notes this stuff, Luke.
Absolutely. We'll link everything for our listeners. And what
awesome.
A thrill to put doctor on everything now. How cool is that?
Oh, heck yeah. It's real cool. It's real cool. Took a lot of work, but it's pretty cool.
Excellent. Well, Jackie, listen, thank you again for speaking with us. Hope to have you on maybe a year's time and see what kind of progress you've made.
Absolutely.
All righty. So moving on from that absolutely fantastic interview, Jackie is amazingly dynamic, very fun to talk to, very knowledgeable in her area. So we thank her for that. We are now going to turn to our Q&A section. So we have some listener, or I should say pre-listener generated questions, because when these questions were generated, there was no podcast yet. It was just existed in our minds, and now we've made it real.
Our wonderful classmates and peers who have faith in us and were willing to give us some questions beforehand.
The subtext of that is people that we bugged until they asked us questions. Let's dive right into these. We're going to go back and forth and kind of try to off the cuff as much as possible these. Maybe need to look something up in the middle, but we just want to make sure you guys have the best answer to your questions.
Yeah.
Jamie, what's our first question?
All right. So @Mike Gosden asks, what is the difference between sarcoplasmic and myofibrillar hypertrophy?
Oh, okay. So in general, the myofibrils are the actual contractile tissue in muscle, and the sarcoplasm is the gelatinous-like substance that surrounds it. So I think a good way to represent this is we think of what are they called? Clowns. Like a clown balloon, like doing balloon animals, a long cylindrical balloon. And inside the balloon are sticks, like long chopstick-like sticks in there. So the sticks are going to be packed kind of like in a honeycomb shape. And if we cut it down the middle, it would look almost like the cross-section of a muscle. So we have these longitudinal fibers running down the muscle. Those are the myofibrils. And then if we fill the rest of the balloon with grape jelly, that would... That's how I love my balloons, with grape jelly. Let's have a water balloon fight. I have a better idea. Let's have the same fun, but get sticky.
Yuck.
Yeah, so grape jelly fights in the heat of summer. Can't recommend it enough. If we filled the balloon with grape jelly that surrounded the sticks, that would be the sarcoplasm. So it's plasm, like a plasmis-like substance filled that contains water. It contains glycogen granules. It contains creatine phosphate molecules, which is our short duration, high intensity exercise substrate. It contains ions. Calcium is in the sarcoplasm. So it's a non-contractile metabolic substance. So we can actually train to kind of increase the volume of either the sarcoplasm or the myofibrils. Now, I will say this caveat is that a lot of newer research is kind of showing overlap between the two, and they're not as like distinctly separated maybe as they once thought. I will admit, I am not a hypertrophy expert, as anybody who's looked at me can deduce.
Stop that.
So you be quiet. All right, I know my strengths. I am a strength and performance athlete. So I would look into Brad Schoenfeld, who is, I believe, at one of the CUNY schools, so the City University of New York. I can't remember, but he is the preeminent researcher in hypertrophy, I would say personally. I'm willing to make that claim on record.
He shares some great Instagram posts as well. Really nice.
Excellent content.
Easy to digest.
Yes.
Even if you're not familiar with, with the stuff that he's talking about, it is really easy to read, easy to digest, and, get his findings.
He also looks uncannily like the father of one of our very good friends, Nick. It's kind of scary. So every time I see him, I think, that's Mr. Myllyaho. Anyway, moving on. So when we train for sarcoplasmic hypertrophy, we're looking to increase the fluid volume of that sarcoplasm. So basically, we want to put more jelly in the balloon, so the diameter of the balloon increases. But it's mainly because of the jelly that we're forcing in there. Generally, we're going to see this being accomplished by higher rep ranges, different mechanical loading schemes. I'm thinking like sets to failure, drop sets, really focusing on depleting the muscles of their stored glycogens. That repletion has that like super compensatory effect. God, I wish our good friend Andy Toronto was here right now, because he would have a much better explanation than I would at this. Whereas myofibrillar training is going to be more of our traditional strength training. We're looking to purely increase the contractile properties of the myofibrils. You may notice I'm hesitating to give certain rep and set ranges because it's more the loading and execution paradigm than it is the volume per se. Volume is not everything. We can see hypertrophy down to rep ranges of even singles, given the right training context. But definitely I would look into the work of Brad Schoenfeld for any more information on this. But basically, we can train differently to drive those two adaptations. I think the perfect example of this, and the stratification of these different adaptations, if we took a powerlifter and a bodybuilder. Powerlifters tend to be less overall muscular, but pound for pound, they are much, much stronger because they train with heavier intensities, lower rep ranges generally, which is going to increase that myofibrillar hypertrophy because extra body mass or muscle mass via sarcoplasm, I could say that, is just going to increase weight. And in a weight class driven sport, if it ain't contractile tissue, it kind of needs to go. It's just wasted pounds in your weight class.
Right.
Versus bodybuilders are looking for the largest muscle size possible. So increasing that sarcoplasm is the way to go. I know Dr. Mike Israetel of Renaissance Periodization, in their hypertrophy templates, they have that like metabolite phase, which is kind of the same thing, looking to increase the waste products, substrate, fluid in the muscle during a training session.
Interesting. Awesome. Yeah. Thank you for that explanation. Hope that answers your question at Mike Gosden.
That's all I got, so I really hope it does. All right. Let's move on to the next question. So at Jash Pimmy, again, these are all Instagram questions. He asks, is there a difference between exercise physiology and kinesiology?
So yes, there is most definitely a difference. Exercise physiology is really going to be focused on what is happening inside the body and how exercise affects those processes in the body. There's different focuses within exercise physiology. For example, Luke and I are both exercise physiology students. However, I'm very clinical focused where he is really not, and that's perfectly okay. It's a very large field, lots to look at. And then we have kinesiology, which is more how our body moves, the biomechanics of our body. So definitely a big difference there, I'd say.
I'd even venture to say that there still is, obviously, there's an internal component
Yes.
to kines. I've taught kinesiology in the past, and the neurological component of muscle control and movement is huge. But we don't get into as much of, like we said, the endocrine systems, substrate, energy systems as much as we do with physiology. But they are two sides of the same coin. We need an appreciation and understanding of one and the other.
We need exercise physiologists. We need kinesiologists. They all kind of work in concert with one another.
You often will see them used interchangeably. Exercise science, exercise physiology, kinesiology.
Sometimes they're all grouped as the same thing, which, I understand. I understand the thought process of, why you might, maybe somebody on the outside of the field looking in might think they're the same, but I think it's important to make distinctions between all of them and kind of appreciate each field for what its strengths are.
I think we'd find that's a common theme across any area. Out from the outside looking in, these things all look the same, but obviously once you're in that area, it's no, they're different.
Yes.
I think if I told my father that all his different coffee roasts, that's just coffee, he would ask me politely to leave the house. Because again, everything has a reason why it is different.
Yes.
In the first place.
Yes.
Cool. That was a great question, I thought.
Oh yeah.
Seems pretty basic, but as we've talked about, like there's some nuances there.
Yeah.
Yes. It's important to know the difference there.
Yeah. All right. So our next question coming in from Helene at Helene of Troy. Can you do a deep dive into sliding filament theory?
Oh boy. All right.
How deep are we going to go here, Luke?
I will go just so I don't smack my head at the bottom of the pool. How about that? All right. So this might bring us over time for the episode, but you know what? This is an important thing to address. So it actually kind of ties in to the contractile properties of muscle tissue that I spoke about earlier. So sliding filament theory, which is rather recent as terms as physiology goes, I think it was only the 50s. Might have been the 30s. I think it's the 50s. When this came about, it's basically the theory that dictates how muscle contracts. And again, when I say muscle, we're talking skeletal muscle here. So we have the brain, which dictates all movement in the human body. So when we decide to move, the brain sends an efferent signal to whatever muscle group is going to be affecting that movement. So let's say we want to flex our elbow, do a bicep curl. All right, obviously we're sending it to the elbow flexors, brachialis, brachioradialis, biceps brachii. And this is accomplished through electrical impulse, action potential from the brain downstream to neurons via the movement of sodium potassium crossing the neuron membrane. So it's basically sending electrical signal down, almost like an Ethernet cable. It's sending a signal from one end to the other.
Zip line.
A little tiny neuron person on a zip line. Yeah.
It's like that SpongeBob episode when he has all those people in his head doing all different things.
Oh,
that's what I'm picturing. Just like a little person on a zip line.
Yes. That kind of is how my brain is working right now. Lots of tangled up zip lines. So untangling them, we have a signal sent down a long line of neurons to the actual muscle group. When that signal reaches the end of the nerve where it contacts the muscle, it's called the neuromuscular junction. So we have the nerve bulb, which releases a neurotransmitter called acetylcholine. This is through the action of sodium and calcium. Cause release of this, it crosses the cleft to the muscle where it opens up acetylcholine receptors that open up gates that allow calcium from the sarcoplasm, what we just talked about too. Nice tie-in of tie-ins there to
it's
flood.
Almost like everything in the body works together.
Crazy. The calcium floods in from the sarcoplasm, which causes a calcium-induced calcium release. So calcium travels down the L-type receptors in the muscle cell itself, interacts with, what are they, James?
Oh boy, is that
RYRs and the
rhinoid receptors,
yep,
and the dihydropyridine.
Yeah.
Receptors.
Oh my God, this is amazing. Dual answered question here. Yeah. So those receptors cause an efflux of calcium from something called the sarcoplasmic reticulum, which is pretty much a storage basin for additional calcium. We need a lot of calcium to generate a muscle contraction. We don't have enough just interest. We have to call on it from all these different places. So this abundant release of calcium causes a shift of certain things on the myofibrils. So again, those long stick-like things we talk about in the jelly balloon. It's a great example. It's coming back already 3 times now.
Jelly balloon.
The jelly balloon.
Sounds like a dessert.
I'll have the jelly balloon, please. Thank you very much. Would you like that with or without sticks? So the long stick guys in the jelly balloon, those are muscle fibers, are myofibrils. The calcium floods to the myofibrils. It binds to a rope-like compound, which is woven around certain fibers on the myofibril called tropomyosin. It binds to something called troponin C, which causes a shift of the tropomyosin around this certain fiber we're talking about called actin. So actin is one of the 2 major filaments in contractile muscle theory. It's what we call the thin filament. It lies parallel to the thick filament called myosin. And the myosin has these little, almost like a little golf club head arms that they want to bind to the actin. However, for the actin binding site to be opened up, that tropomyosin needs to shift. So the calcium binds to troponin C, which causes that conformational shift in the tropomyosin around the actin, exposes the binding sites. And the little myosin grabby hands grab on to the actin and they yank it towards it. And you have this movement of the fibers against each other. This happens, I'd say, millions of times all the way down the length of the entire myofibril. And it actually shortens the entire myofibril. And that's what causes muscle contraction. All right. I will say also that it's not one long fiber, thin and thick. Each myofibril is divided up into little tiny subsections, almost like if you had a piece of, like a chive, and you chopped it up in little sections. That's what it would look like. There's little subsections called sarcomeres, which consist of their own myosin and actin, which contract on each other. This shortening happens in each sarcomere all the way down the myofibril, and thus the entire muscle shortens. And we have movement. All right, so that is sliding filament theory. It's why things like calcium are so important to the body, that they're used so much. It kind of ties in that neurology piece too.
Yeah, absolutely.
Which is pretty cool. Wow. Well, that was quite a question for the first episode. I hope I answered it well.
Yeah, I'd say so.
All right. Next up, at ULifts asks, what are the elements that go into programming for athletes?
So the overarching kind of acronym that we use when we refer to exercise programming is the FIT VP principle, which stands for frequency, intensity, time, type, volume, and progression. So all of these components are really important for an effective program, whether it's for an athlete, for an untrained individual, a clinical population, really can be applied to all forms of programming. So, as a coach for, whatever sport that athlete plays, you're going to have to take all of those into consideration. Another thing, specifically with athletes is you have kind of these big macro cycles of training dependent on whether they're in season or off season. Training is going to be different. Off season, we might see some more general work being done, maybe some hypertrophy work, some strength work, kind of not super specialized work in the off season. And then when you get into in season, you're going to be doing more of that sport specific, very specialized work that coincides with their sport and how they are expected to perform in their sport. So definitely a lot of things to take into consideration when programming an athlete. and really up to the strength and conditioning coach to apply whatever methods he feels are best, or her.
Oh, absolutely. To tack onto that, I think one of the things that, since the question asked this, separates training athletes from non-athletes, recreational individuals, is that the timeline of goal-oriented progress is so much more accelerated.
Yes.
And in particular.
Yes.
There's certain performance variables that have to be met. Maybe certain anthropometric things like, there needs to be this body weight.
Yep.
Or ball needs to be thrown this speed. And, it's a very high-pressure situation.
Oh, yeah.
Historically, what I've known is that when teams do poorly, the strength coach is one of the first people that's cut from the program, unfortunately. So very happy not to be working in that realm anymore. We both spent a decent amount of time in the strength and performance realm.
Too long.
Yeah, it was good. I think we learned valuable skills.
Listen, we learned what we don't want to do, which is a valuable knowledge.
It's the same reason why we publish null findings. Sometimes you need to know what doesn't work.
And that's, nothing against strength and conditioning coaches who are needed and you are valued. We are just not going to be
And thank you for doing the job so that we don't have to do it. Awesome. I think we might tack this on the list of new episode ideas because to give a rundown on programming for athletes could take a semester.
Yes.
Let alone an episode or let alone a 3-minute segment.
Yeah.
Cool. Great question, Ulifs. Thank you for that.
All right. So moving into our last question of the day from OTF coach David. What are your thoughts on fascial stretch training theory?
My thoughts are that it sounds really hard and it sounds like absolute hell. Fascia is a connective tissue that surrounds our muscles. So we think about it like all these myofibrils, they form bundles, and the fascia kind of surrounds these bundles. If you think about like a deep undersea cable, there's obviously, metal cable or fiber optic cable in there, but you have this thick outside rubber or whatever insulating material that protects the cable, which sharks have actually been attacking the transatlantic cables they lay. I think that's pretty interesting. Trying to reclaim the oceans. They saw Aquaman and got really really fired up about that. Yeah. So we're going to need a bigger cable. So the fascia is this connective tissue, like we said, surrounds the bundles of muscle fibers, and the premise of fascial stretch training, and I put another caveat here, I am not a bodybuilder. All right, so this is purely kind of educational research informed knowledge, or people that I've known that have used this. I think probably one of those famous bodybuilders who've used it was Jay Cutler back in the early mid-2000s. Yep. I know he was a big proponent of this. I remember watching in my undergrad class a FST 7 video, so fascial stretch training 7. So the 7 stands for the 7 sets you perform at the end of your workout, targeting a certain muscle that you want to employ this training method on.
Got it.
I want to say there's 7 sets to failure.
That sounds terrible.
It sounds awful. And we're avoiding compound movements, isolation, purely to force as much blood, nutrient, metabolite into that muscle, into the sarcoplasm. So again, this ties back now to the first question, to get the biggest pump in the muscle, to literally stretch the fascia. The idea being that the corresponding muscle underneath will almost adapt to occupy this new stretched fascia, almost giving it room to grow in a way. Kind of like if we blew up the balloon so that we could force more jelly and sticks into it.
Here we go with our jelly balloon.
This is a fantastic example.
We gotta trademark this.
Yeah.
This might be like our $1 million idea.
Luke and Jamie's jelly balloons. Look for us on Etsy soon. Yeah, so again, I'm going to call it there on this question before I say something totally incorrect. If you are a bodybuilder listening to this segment and you have some information on this, and I'll say this for anything we talk about on the podcast, we love, first of all, being told that we're wrong. That's great. And we love correct information. We love finding new things. The only reason we're students as we approach our 30s is that we love learning new information.
Yes.
We can't get enough of it. So if there's anything on the podcast you have insight on, I implore you, please contact us. We will give you a shout out. Unfortunately, we can't pay you, but we will definitely cite our sources since we are scholars at heart. And we love to tell our listeners, that piece of information that we were missing.
Yeah.
Not afraid to admit that we were wrong or didn't know something.
Absolutely. I have that on record now, though, that we're not afraid to admit that we're wrong, right? Or we love being told.
In podcast related terms. I need to speak to my lawyer before I say anything else.
And that wraps up the very first episode of the ExPhysCast. Before we go, just going to give you some information about upcoming events, conferences, webinars, etc. So the New England chapter of the ACSM, or the American College of Sports Medicine, is holding their 2021 spring conference on April 23rd. Their focus is surrounding physical activity in the new normal, science to practice. And we will link that registration sign up in the show notes. Secondly, the NSCA, or the National Strength and Conditioning Association, is holding the 2021 National Conference this July in Orlando, Florida. Hopefully, vaccinations will be rolled out by then. It'll be safe to go. And again, the link for that will be in the show notes. This is your reminder to like, comment, and subscribe via YouTube. And just keep an eye out. We're hopefully applying to be on Apple Podcasts within, the next couple episodes. I think once we get to that 3-episode mark, they'll probably accept us. But we'll let you know, of course. And stay tuned for the next episode on April 30th. Keep learning, keep living, and we'll see you next time.